Hey guys, welcome back to Ace the AMC. So today we have a cardiology type question, recall question. So a lot of important features within this question that we're going to go through. We'll get straight into it. So which of the following clinical features best distinguishes cardiac tamponade from early constrictive pericarditis? So importantly, when we're looking at these questions, we'll talk about each of the answer options, but I guess the important thing first of all is to know what cardiac tamponade is. Okay, so this is when you have an abnormal accumulation of fluid within the pericardial sac, and then you have constricted pericarditis, which is when you have fibrosing or scarring of the pericardial sac, so it kind of becomes stiffened. So with cardiac tamponade, it's very important to remember the triad. So that's Beck's triad. So this is where we have hypertension, muffled heart sounds, and raised JVP. Okay, so it's important to understand why this happens. This many times on my rotations. So raised JVP is because if you think about it, the heart is surrounded by the sac, and now the sac has a lot of fluid in it, so it can't fill as much. So that blood coming into the heart has to go somewhere else, so it goes back up into the venous system and causes a raised jugular venous pressure. Muffled heart sounds, this is pretty non-specific and doesn't necessarily correlate to anything much or is used much in clinical practice, but you would see muffled heart sounds because there is fluid around the heart, so it will be difficult to hear on auscultation. And then hypotension, obviously that you have decreased cardiac output. How do we distinguish between cardiac tamponade from early constrictive pericarditis? Okay, and it's important to know that hypotension is seen in late stages of constrictive pericarditis. So you still have a good cardiac output in the early stages, okay, which means you're able to maintain your blood pressure. But in cardiac tamponade, it's usually acute and there's a lot of fluid accumulating fast within that pericardial sac, okay? So that's why you get hypotension quickly. So we'll also just talk about the other answer options, pulsus paradoxus. Okay, so pulsus paradoxus is where you have a greater than 10 millimeter of mercury fall in systolic blood pressure on inspiration. Okay, this is more seen in cardiac tamponade than it is in constrictive pericarditis. So you remember normally during inspiration, your inthoracic pressure falls. Okay, this draws more blood into your heart. Okay, this comes into the right ventricle, causes the interventricular septum to shift into the left ventricle, which then means the left ventricle is able to fill less, which means you have a small, not greater than 10, but small decrease in your systolic blood pressure. In cardiac tamponade, you have decreased filling of your right ventricle, which means that when you inspire and the intrathoracic pressure drops, it draws blood more into the heart. And the right side, it bows the septum even greater. And that septum has to go into the left ventricle, which means that the left ventricle is filling even less, which means that you have a drop. That's why you have a drop of greater than 10 millimeters of mercury. Okay, we'll then talk about Kussmaul's sign. So Kussmaul's sign is where you have a rise of your JVP on inspiration. So like we talked about pulsus paradoxus, Kussmaul's sign, normally what happens is you inspire, intrathoracic pressure drops, you draw more blood into the heart, which would mean that your JVP would decrease as you're breathing in, okay? Opposite in Kussmaul's, so it actually increases. Okay, that's because this usually happens in constricted pericarditis, and that's where the sac is fibrosed or scarred and the right ventricle is stiff. Okay, so it can't dilate as much or let as much blood in. So the blood actually backs up and shoots back up into the internal jugular vein, which is where you're looking at your JVP. So important to remember one more thing about JVP is that when you're asking someone to do it, okay, you ask them to look to their left, okay, you have them at 45 degrees, ask them to look to the left, and then you find the two heads of the sternocleidomastoid and look in between those. You then find the sternal notch and you look if it's less than 3 centimeters, that's normal. If it's more than 4 centimeters above the sternal notch, okay, you can classify that as a raised JVP. So just to recap, the answer for this was hypotension. Okay, that's because you see this in late constrictive pericarditis, but it is very early on. It does happen quickly in cardiac tamponade. So if you're enjoying these videos, please like, subscribe, and comment.